Okay. So good morning, everyone. It is a pleasure to be here presenting and hosting this event for you today. Thank you for spending your precious Saturday mornings with us. My name is Dr. Huren Sivaraj, and I am the CEO and co-founder of the Oncoshot platform. So Oncoshot is a cancer platform that works together with patients, oncologists, and innovative treatment partners to help patients find the expert care and innovative options that they need. And today we are collaborating together with the Breast Cancer Foundation to bring to you a series of webinars to help inform and keep you updated about the potential knowledge that you might need, as well as options of how you can tap into the ecosystem of care providers in Singapore. So I'd just like to introduce all of you to our speakers today. We have with us Dr. Sim Yirong. Dr. Sim graduated from the University of Cambridge back in about 2009, and she subsequently obtained a fellowship with the Royal College of Surgeons, Edinburgh in 2016. Her focus and interests are in breast cancer research and education, and she's currently a consultant at the Division of Surgical Oncology at the National Cancer Centre, Singapore. Thank you for joining us today, Yirong. We also have with us Dr. Lynette No. Dr. Lynette is a medical oncologist who specializes in women's cancers, particularly breast and gynecological cancers. And her areas of interest also include hereditary cancers, genetic counseling, and psychosocial oncology, as well as pediatric medicine, in addition to general oncology. Dr. Lynette works in Curie Oncology, and we are really happy to have her with us today. She will be presenting to us the keynote presentation for approximately about 10 to 15 minutes. I should be covering a lot of the key issues in terms of the incidence of cancer, screening modalities, as well as some tips on prevention for cancer as well. And we also had with us Ms. Samantha Seah, who is the General Manager from Breast Cancer Foundation. Samantha has been a part of Breast Cancer Foundation for some time. She's also a friend of Oncoshot, having worked with us in previous webinars. So Samantha will be sharing some of the key services that Breast Cancer Foundation is providing for our community of patients, as well as members of the public, to help them in their management of their general health, as well as if they have a cancer diagnosis. Now, without any further ado, I'd like to now ask Dr. Lynette No to start off this event with the presentation. Thank you, Lynette.
Thank you. Hi, everyone. Thank you so much for joining us from home on a precious Saturday morning to learn more about breast cancer. And I want to thank Oncoshot for inviting me to share more about screening and diagnosis of breast cancer. I'll share my talk. Okay, I hope you can hear me. So we know breast cancer is the most common cancer in women in Singapore. In fact, it's the most common cancer in women in most parts of the world. It comprises almost 1/3 of all breast cancers diagnosed every year in women. In fact, every day, almost 4 women are newly diagnosed to have breast cancer. It's also the most common cause of cancer deaths in women. So what can we do about it? I'll be going through some of the signs and symptoms of breast cancer, how we diagnose breast cancer, what are some of the risk factors for breast cancer, and what are the screening recommendations for breast cancer. So what are the signs and symptoms? So here are some of the more common myths about breast cancer. Just last week alone, I had 3 appointments, 3 women who scheduled to see me because they developed breast pain and they were worried that it would be breast cancer. The truth is, most breast cancers are actually not painful. And breast pain can be a result of infection, inflammation, or even premenstrual hormonal changes. A lot of women get breast pain premenstrually, which then disappears. On the other hand, some women actually tell me that they didn't seek medical attention because the breast lump is not painful and they just wanted to watch and see what would happen. Most breast cancers are painless. So the red flag or the warning sign of breast cancer is if you find a painless hard lump. Again, some other women say that, oh, because my mom had breast cancer, so I'm definitely going to get breast cancer. What should I do? there are actually many causes of breast cancer, and only 10 to 15% are linked to genes. A lot of breast cancers are sporadic. It could be caused by environmental factors, smoking, high-fat diet, radiation, and so on. And sometimes it's just caused by chance because of accumulation of mutations over many, many years. And some young women tell me that they didn't know that they had breast cancer because they thought only older women got breast cancer. It couldn't be them. Actually, the incidence of younger women with breast cancers is on the rise. So anyone can get breast cancer, even men can get breast cancer. And finally, if it's only a rash, it may not be cancer, but there is also a rather rare disease called a Paget's disease, where it actually appears as a rash around the nipple. So even if it's a rash that doesn't go away, you should seek medical attention. So in general, the red flag is anything that does not resolve should require medical attention. And here are some of the common signs and symptoms of breast cancer. It could be a lump or thickening. Most of the time it's in the breast, but it also could be under the armpit. More rare, but also possible, could be a nipple discharge or bleeding from the nipple, or a change in the shape. So if there is a protrusion or a depression in the breast, that could also indicate something. It also could be a change in the appearance of the areola, which is the area around the nipple, or if the breast simply looks red and inflamed, or if there's pitting of the skin like an orange. So 1 in 13 women in Singapore will get breast cancer, and most of these breast cancers are painless. But the good thing about breast cancer is that early breast cancers are entirely curable. More than 90% of early breast cancers can be cured, which means it will never come back to bother you again. So the important thing is to pick up breast cancer before it spreads to other areas, because once it has spread to other organs, it becomes a lot more difficult to treat. So early detection is key. So what can we do? Let's take a look at the normal breast anatomy. So breast milk is usually produced in the lobules or in the glands of the breast. It's then secreted through the ducts and then externally through the nipple. This is a cross-section of the breast duct. So most of the time, breast cancer develops in the lobules, in the glands of the breast, or in the ducts, more often in the ducts of the breast. And if the cells lining the ducts become abnormal, there's uncontrolled growth, then cancer develops. So if the abnormal uncontrolled growth appears in the wall of the duct, it doesn't break through the wall of the duct. We call this ductal carcinoma in situ, or DCIS. And this is pre-cancer. It is before it turns into cancer. And this is the stage we want to catch the cancer, before it turns into cancer. If the abnormal cells grow through the wall of the duct, there's a potential that it could spread to surrounding areas. We call this invasive ductal carcinoma, or breast cancer, what we commonly know as breast cancer. And the problem is that once it starts to infiltrate into the surrounding structures, it could potentially go into the drainage system of the breast, which is the lymphatic drainage or the bloodstream, and could spread to any other areas. So how can we diagnose breast cancer? Generally, the best screening tool for breast cancer is a mammogram. Sometimes we may need to add on the breast ultrasound, but the confirmatory test for breast cancer is with a biopsy. So this is what a mammogram machine looks like. It's actually a low-dose X-ray. It emits X-rays through this diode. It passes through the breast, and then it's captured by the X-ray film below. Usually the breast will need to be compressed by plastic plates. This is so that the breast tissue is all spread out so that the rays can pass through the breast easily. And nowadays, most of the time, we use a digital mammogram rather than an X-ray film. This is because we are able to convert these X-rays into electrical signals, and then we can put it on the computer, and the resolution is much better. We can magnify that. And mammograms have been shown to show changes in the breast up to 3 years before you can actually feel anything. So a mammogram is a very important screening tool. And what does a mammogram show? So if there is a breast lump, it can show up as a mass, or we could see microcalcifications. So microcalcifications are actually little specks of calcium that appears as white spots in the breast. And a lot of the times, early breast cancer and pre-cancer shows up as tiny specks, microcalcifications. So this is the part where we want to diagnose. And a mammogram also allows us to tell whether these masses are more likely to be cancerous or not. So a benign mammogram change would be something like that. Has very smooth edges, very benign looking. Whereas if the edges are very irregular, we call it spiculated and irregular edges, then it's more likely to be cancerous. Some women have dense breasts. So when a woman is younger, there is a lot of fibroglandular tissue in the breast, and sometimes the x-rays are not able to penetrate through the breast adequately, and it may appear very opacified like that. As a woman gets older, the breast tissue becomes fattier, there are fewer glands, and the x-rays are able to penetrate it better, so the breast becomes more translucent. And usually if there is a mass or if there's calcifications, we can see this, we can detect this more easily. So if a woman has very dense breasts, on the x-ray it appears all white. So if there are any opaque masses or microcalcifications, we can't quite see that. It may obscure these changes. Sometimes we may need to add on additional modality like an ultrasound of the breast. So the ultrasound of the breast is actually high frequency sound waves that are actually emitted by the diode. And then it passes into the breast and are then received back by the transmitter, which then converts it into X-ray, converts into electrical pictures. And this also allows us to tell whether the mass is more likely to be cancerous or not. So again, if the lesion has very smooth edges, is completely black, we call it a hypoechoic, then it's more likely to be non-cancerous. Whereas if the edges are very irregular and inside is very heterogeneous in looking, is more likely to be cancerous. So if we suspect the mass is abnormal, it looks very suspicious for cancer, then we would need to go on to do a breast biopsy. And a biopsy is the confirmatory test for cancer. So basically, a needle is passed into the breast where the lesion is, and then small amounts of tissue is removed and sent to the lab. They look under the microscope and the pathologist will tell us if it is indeed cancer or not. So what are some of the risk factors for breast cancer? In a study where they looked at all the different risk factors for cancer, actually the #1 risk factor is age. Any woman 70 to 74 years of age has an up to 18 times increased likelihood of developing breast cancer than a woman at 30 years of age. So if you look at the incidence of breast cancer, the incidence of breast cancer actually starts to climb up from 40 years. It peaks at 60 years, and then it slowly comes down after that. So the time when we want to do mammogram screening is at between 40 to 50 years of age. So the screening recommendations are breast self-examination. Every woman should be familiar with her breast so that she would know if something new or abnormal develops. Screening mammogram is usually recommended from the age of 50 years onwards, and it should be done every 2 yearly. Sometimes a woman has an increased risk of breast cancer. For example, if she's a chronic smoker, if there's a family history of breast cancer, then we might want to start screening from the age of 40, and this should be done every year. If there's a very, very strong family history of breast cancer, then we would sometimes need to add on other modalities of testing to detect breast cancer more easily. Unfortunately, only 20% of all cancers in Singapore are found by mammogram. In some other countries, up to 40% are non-palpable and found on screen, and that's what we hope to achieve one day. The second most common risk factor for breast cancer is actually a gene mutation in BRCA1 and BRCA2 gene. So in 1983, when the scientists were studying Jewish families, the scientists were studying Jewish families with a very strong incidence of breast cancers or ovary cancers in the family, they discovered the BRCA1 gene. 1 year later, they discovered the BRCA2 gene. So this is a picture of ourselves. So all of us have 23 pairs of chromosomes. And they found the BRCA1 gene on chromosome 17 and the BRCA2 gene on chromosome 13. BRCA genes are actually DNA repair genes. So these are genes that repair any damage. So every day when we're exposed to cigarette smoking, exposed to UV light, exposed to radiation, our cells will undergo some mutation. Fortunately, we have the BRCA1 gene and 2 genes to repair all these damages from our cells. For individuals who lack the BRCA1 and 2 gene, they are not able to repair these changes in their genes. As a result, all these mutations accumulate faster and they develop cancer at a much faster rate. So an individual with a BRCA1 gene mutation would have an up to 85% risk of breast cancer, as opposed to a 10% risk for all of us. A higher risk of ovary cancer, up to 50%, and also other cancers. An individual with BRCA2 gene mutation not only has an increased risk of breast cancer and ovary cancer, there's also an increased risk of pancreas cancer, laryngeal cancers, and even men have a risk of male breast cancer and prostate cancers. So how do we know if we have this BRCA gene mutation? It's a simple blood test. So we need a genetic test to prove that. It's usually a blood test, or it could also be a buccal scrape or buccal smear, but not everybody needs a gene test. So the recommendations, the risk groups for the BRCA gene mutations are if a family member has breast cancer younger than 50 years of age, because as we saw from the incidents, most people develop breast cancers when they're 50 to 60 years of age, and if they're younger than that, something else could be the cause for the breast cancer. Or if there's a very strong family history of breast cancer, or if there's breast and ovary cancer in the same woman, if a woman has 2 breast cancers, if a man has breast cancer, or if there's a Ashkenazi Jewish heritage. And usually anyone who requires a genetic test would need to be referred to a genetic counselor, who will then go through the risks, the pros and the cons, the implications of having an abnormal genetic test. But getting a genetic test result that is abnormal, does that imply just all bad news? Well, we know that knowledge is power. So by knowing that there's a BRCA gene mutation, individuals can increase their cancer screening. So usually, instead of just doing a mammogram from the age of 40 or 50, we would start annual mammogram screening from the age of 25 or 10 years before the earliest member who has a gene breast cancer. We will also add on MRI breast to just mammograms. We will also teach the individual to do breast self-examination from the age of 18, and they should also be seeing a medical professional to do clinical breast examination from the age of 25. But is that all that we can do, just breast cancer screening? There are also medications available. So there is a medication called tamoxifen. So Marie Claire King in 2001, she treated BRCA2 mutation carriers with tamoxifen, and she found that it reduced the risk of breast cancer by 62%. And of course, there's always preventive surgery. So in 2013, Angelina Jolie famously announced to everybody that she was going for a bilateral mastectomy because she had a BRCA1 gene mutation. So women who had bilateral mastectomy, it was found to reduce the risk of breast cancer by 90%. And because there's a risk of ovary cancer as well, if a woman has completed her family, she could also opt to remove her ovaries. And removing the ovaries reduced the risk of ovary cancers by 95%. And not just ovary cancers, it also reduces the risk of breast cancer by 50%. So there are things that can be done to prevent breast cancer. So we know that breast cancer is a top cancer in women worldwide. 1 in 14 women in Singapore will develop breast cancer. So understanding our personal risk of breast cancer will then allow us to do breast cancer screening and prevent. And even if breast cancer develops, we know that we can cure it if we detect it early. So I think that brings me to the end of my talk. I'll be happy to answer questions a little bit later.
Thank you, Lynette. So thank you for the overview of breast cancer, as well as some of the risk factors that are important to consider, and what steps some of our patients can take in terms of screening, and keeping in mind in terms of how they can minimize the risk of cancer as well. I think I'd like to now call Samantha to kind of share from the perspective of Singapore's breast cancer patient support group, which is the best Breast Cancer Foundation about some of the activities that they are involved in to help patients get access to improve cancer screening. And Samantha, all over to you now.
Okay, good morning, everyone. Thank you for spending your morning with us. And we just wanted to just highlight what we're about. Let me just share my screen. Okay, open this. Okay, so what are we all about? We are here to support every woman and their caregiver going through this journey. And I wanted to share with you that as we know, breast cancer is the #1 cancer amongst women, and our mission is to really try to raise awareness and advocacy of how we can help prevent this. You can see here in this picture, all our women, we were all, it was taken a couple of months ago where we had to say, stay at home. But what I wanted to show you is that this journey is not a journey that you go through alone. It's many helping hands. And these women and their caregivers and their support family members, as well as the doctors, have played a major role in ensuring that they are continuing to be the warriors that they are. Okay. So as what Dr. Lynette had just said earlier, 1 in 13 women will be diagnosed with breast cancer before the age of 75. Now, this number has actually increased threefold in the last 50 years in Singapore. And that really is quite a challenge because if these numbers are increasing, then our role now is to ensure that everyone takes that positive step into building awareness and building the early detection, because survival is very, very high when it's detected early. What do we have available? Now, what Dr. Lynette had just shared, and I'm just repeating, I think what's really key is the breast self-exam. Okay, this, I think you can do it every month. And this is something that you can do in the shower, in the mirror, when you're lying down. And of course, usually when you do it, if you're still menstruating, it should be 7 to 10 days after your menstruation. But if you have completed your menstruation, then it should be done once a month, and fix it at a specific date. Once you are more familiar with your breast, the shape, if there are any changes in terms of the shape, the size, any discharge, please get to your doctor as fast as possible, because prevention is key in this whole process. And as what Dr. Lynette had said, mammogram screening is key. For Breast Cancer Foundation, we do have a full sponsorship program that addresses all the needs for those women aged 50 years and above, and if they have a valid community trust card, either blue or orange. And this is available at all polyclinics. We had shared earlier that psychosocial support is really, really important. And during this COVID times, I think it's important that we do have as much support group as possible. And as such, we have online support group, caregiver support group, and we've just launched the Advanced Metastatic Breast Cancer Online Support Group. This is a safe environment that everybody is welcome to join in, and you can just share in a private space with all our volunteer befrienders as well as counselors who are actually warriors themselves that have gone through this, okay? And as what we've said, education is key. It's all about empowerment. And we do run empowerment programs, and I'm just going to highlight one of these programs that we run for both the breast cancer survivors as well as their caregivers and their families. And this usually is a workshop that we would run once. I think it's more important in a group setting. So once the safe distancing has been lifted, we will then run this properly. And this year we talk about how we're able to walk that journey, and we equip every woman as well as their caregiver and their family members how to manage this journey alone together. Should you then be diagnosed with breast cancer, we do have a positive rebuilding program. Now this, we have two. One of the major side effects of chemotherapy treatment is actually the loss of your hair. So we do have a wig loan program, and this is something that is complementary of which we will engage you in a very warm, welcoming, comfortable, and exclusive environment where you can share with us, and It's a one-to-one appointment, and this is one that we can help you in regaining confidence if you're on that chemotherapy treatment and program. Here, we also have a positive prosthetic bra service, and this is actually available at all public hospitals. This needs a referral from the medical social worker, but it is really more for the lady who's had the mastectomy and needs the prosthetic bra. So I think that's what I have to share. I would like to thank you for your time, because I believe there's a lot of questions that we need to answer going forward. Yes, lots of questions. Thank you.
Thank you, Samantha. Actually, over the last 2 webinars that I've conducted with the Breast Cancer Foundation, I've learned so much about your activities. In fact, it's almost become a mandatory thing for me to actually share with my new patients about some of the services that you do provide. And I think a lot of them have actually benefited and come back to tell me that they were glad they knew about the services that BCF was providing upfront, because it probably did make a certain difference in terms of how they were able to handle their diagnosis. So thank you for the work that you guys do. We really appreciate it from the doctor's perspectives as well. I think let's now move on to our Q&A session. We have with us also Dr. Sim Yirong, who will be participating in our Q&A session. Dr. Sim is a breast cancer surgeon specializing in oncologic surgery, and she'll help to answer a lot of the questions that we received at registration, also centered around management of breast lumps, when should we go for surgery and things like that, and also some of the new diagnostic modalities. We had a few questions from some of our registrants from India as well as in Singapore about new innovative diagnostic tools, and we try to use this opportunity to answer some of them, and hopefully we have the time. Please keep your questions coming in. I know a lot of you have already sent those questions in at registration, but please feel free to use the Q&A box to ask your questions, and we'll try to address them as well. So Yirong, without further ado, maybe I'll just start off with asking you one of the first few questions. So we had a patient who on registration had mentioned that she felt lumps in her breast. Now, the first question really was, how do we know the lump that we feel is likely to be malignant or benign? Are there some features that you would think would be important to consider? I think Dr. Lynette had kind of mentioned a few things as well, but maybe you could kind of summarize from your perspective as a surgeon as well.
Okay, good morning, everyone, and also thank you to Oncoshot for giving me this chance to share with everyone. Just to begin with, breast lumps are very, very common, but yet it is also very worrying to the lady who first feels her breast lump. So how do we tell whether a lump is benign, that is not cancerous, or cancerous? There are a few key things which I think Dr. Lynette and Samantha have shared with us. So the main thing is lumps can be non-cancerous, so i.e. they can be like breast cysts, which are little water bubbles, which are totally fine, or they can be little solid lumps like fibroadenomas or fibrocystic change, which do not need surgery, they're not worrying. But what the more importantly is a lump that does not go away, a lump that is new, a lump that keeps getting bigger, and a lump that has skin changes. That means changes to the color of the skin, when it making it red or dark, or if it's causing an ulcer, or if it's causing the skin to swell or dimple. If there's also changes to the nipple, like a rash, or if there's nipple discharge. And also if there's other lumps associated with the breast lump like that in the armpit, or the breast shape is changing. All these are worrying signs, or even if you have any of the above or none of the above and are concerned, I think the best thing is to see a doctor and we'll discuss and examine. And what your doctor would do was not just examine. If there are concerns, we will do further imaging, just like a mammogram or an ultrasound. And these will give us additional information whether the lump is cancerous or not. And I think as Dr. Lynette briefly mentioned earlier, so signs of the lump is not to worry about. So if it's a water bubble, we can see like a cyst, we can see that on an ultrasound. If it's a benign lump like a fibroadenoma or sometimes a small papilloma, there's something that's very round, very smooth, very nice margins, wider than taller. these are signs that they probably can be left alone, but we will usually like to monitor them for at least for follow-up, at least up to 2 years, to make sure they're not growing bigger. Things that are worrying, things like certain sort of calcifications on the mammogram, not all calcifications, but certain patterns that are worrying, lumps that are hard, irregular in shape, and these are things that will make the doctor worried about cancer, and we'll discuss with you further investigations like a biopsy. Yeah, so not all lumps need to be removed, but they should be investigated and monitored. Yeah.
Thank you, Yirong. One of the questions that also came up, as I referred to earlier, was also about, diagnostic tool, because, we've been largely talking about cancer screening and, trying to get our patients to even firstly come onto the screening program that we have in place in Singapore. That's been, there's still quite a room for us to improve on that. Now, there are also new screening modalities that have been evolving, and some exciting modalities as well, where, we are looking at the combination of new technologies with AI, for example. And one of the things that, we've had a recurrent question over the last 2 webinars as well was, what is the oncology community here? What is our perspective of new technologies, like, for example, thermal imaging, and whether you know of any other tools that may, be useful for screening of breast cancer today?
Thank you. So everyone's excited about new technology, and I think we should be. I think like thermal imaging, for those who us may not be familiar, is sort of the things that actually is more commonplace now as we deal with the COVID pandemic. We have this screen that checks our temperature wherever we go. And this is an example of thermal imaging. And I think I was reading there's even a news somewhere in England or Scotland, where a lady went to a museum and the thermal imaging picked up a warm signal from her breast, and that's when she went to get it checked out that it was breast cancer. So thermography or thermal imaging is using this special camera to measure the temperature of the skin on the breast surface. It's non-invasive, has no radiation, and it's believed to work. The idea behind it is that cancer cells grow fast. They multiply quickly, they have increased blood flow or high metabolism, and therefore the temperature of it should go up. There's all this research into this new imaging. However, I must say, with anything that is new, we don't have enough data to justify before it is used commonly. And to date, the sensitivity and specificity of this thermal imaging is still not as high, as good as our gold standard, which is a mammogram. So our mammogram is sensitive to more than about 90+%, and the new thermal imaging is still not as high. I mean, depending on which paper you read, maybe about 60 to 70%. And then as such, even it's not approved by FDA in most countries and not locally in Singapore to be used. However, we can still watch that space in future if it's when we understand this technology better and we can adapt it to our local population as well and to different breast shapes and sizes. Maybe that could be used, but maybe in the future. But in the meanwhile, the standard technology that we use for screening is still a mammogram. And if something abnormal is picked up, your doctor may also order a supplementary imaging like ultrasound or an MRI to help further characterize the lump or lumps in your breast.
All right. Thank you, Yirong, for that. So maybe I would like to just go on to some of the questions regarding prevention that were asked, and maybe I could address this to Lynette. Dr. Lynette, one of the common questions actually was from 2 perspectives, from individuals who may not have had cancer and also from individuals who have had cancer previously and who completed their treatment. Now, how can they prevent relapse? Especially, is there a role for diet and exercise in firstly preventing cancer from occurring? And for those patients who've had the cancer experience, would diet and exercise also prevent cancer from coming back or relapsing?
Yes, most certainly. So we can look at for breast cancer survivors who have already had a mastectomy or a lumpectomy done, who had the surgeries. Usually the doctors would recommend additional treatment to prevent the breast cancer. So once they've had that additional treatment, it could be medication, hormone treatment, or chemotherapy or radiation, all these modalities were already helping to prevent a second recurrence. However, we also know that there are multiple causes for breast cancer, and some of them are as what you have mentioned, are environmental factors that we can actually control. So let me share my screen. So when they did a study looking at all the preventable risk factors, tobacco smoking was one of the biggest risk factor, followed by excessive body weight, alcohol intake, ultraviolet light, poor in diet, and so on. So recently, American Cancer Society actually just June this year came out with some guidelines to prevent cancer. And it's been found that for breast cancer in particular, weight gain is one of the risk factors. And physical activity has been shown to reduce the risk for breast cancers. So their recommendations is that every adult should engage in at least 300 minutes of moderate intensity physical activity per week, 150 minutes of vigorous intensity physical activity a week. And these are all evidence-based. They are based on numerous studies looking at prevention for cancers. They also recommended increase a healthy eating diet, reducing the amount of red and processed meats, sugar-sweetened beverages, and highly processed foods. There was actually a recommendation against totally not drinking alcohol, but we know that this is very difficult because it's probably been ingrained in us as a social activity. So for people who are not able to completely abstain from alcohol, women should limit their consumption to 1 drink per day and men 2 drinks per day. So yes, there are things that we can do to prevent cancers. It's more important as a maintenance to include this into our daily lifestyles and our regular activities.
Oh, thank you for that. So it's actually been quite interesting because this entire evolution about the role of exercise there's a lot of research that's actually been happening and coming out, even in the space of patients who are on chemotherapy and the impact of how exercise can actually improve some of outcomes while on treatment as well. So it's a really exciting space to watch. But I think fundamentally, certain truths that we've kind of known all along, they kind of, hold true no matter what, which is, if you can get off your seat, exercise on a regular basis is probably going to help you more than many other things that you could do. So maybe I'll just go back to Yirong for one of the interesting questions that we've had. So we've generally asked a lot of the questions or the presentation in terms of very general guidelines, but we do tend to see questions that come very specifically for certain patient groups. And one of the patient groups which we probably want to discuss at this point is centered around the elderly individuals who may be diagnosed with cancer. And as we know, as women get older, their risk for cancer also increases. Now, one of the questions that we had was a lady who asked us, her mother is 74 years old, generally fit, but she's old and she has a breast lump, which is most likely cancerous, and they're going for a biopsy. Now, in the event that this is a cancerous tumor, and it's just there within the lump, generally, would you advise for elderly patients to have it taken out, or could we just leave it and watch it in some cases as well?
This is a very good question, and it's a question we face very regularly. That's because we're all living older. We're all living older and older now, and the average lifespan of the woman in the world, or in Singapore, is actually very high, more than 80, 85 or so. And the older we live, the more problems we have, not just other health problems, but also the increased risk of breast cancer. So that comes to the question that should we treat a breast cancer in elderly women? And I think, yes, we should still at least seek treatment, seek investigation, and not run away from it. And this is because firstly, surgery is fairly safe in most women, even above the age of 80, because our modern anesthesia actually allows for safe anesthesia and surgery. And we even had a local paper, if Dr. Huren can show, that it also shows our local data where women in Singapore above 80 actually tend to for a few things. It tends to show that the women in Singapore tend to present with higher stage of cancer. So the breast cancer ranges from stage 1 to 4, depending on the size of the lump, the number of lymph nodes, and whether they're spread. And the higher the stage, the bigger the tumor is. And it's probably not surprising that more the women above 80 tend to show higher stage cancers than the younger ones, maybe because they take a longer time to present to the doctor, and also maybe because they're not undergoing screening as regularly or at all, which means the cancer is not being picked up as early as we like to, as in the younger population. Nonetheless, even despite that, we have shown that even with women, as you see the one in the red, the second line from the top highlighted in red, women with more above 80 who undergo surgery still tend to do better than those who do not undergo surgery for the same age group. And they tend to have a better overall survival, and that's because they are being treated. And compared to the younger population, which I don't have the slides here, the elderly women do not perform any worse than our younger women for early stage cancer. Now, then for later stage cancer, then it's a personalized decision between the patient and the doctor as to whether they should undergo surgical treatment. And what makes us decide is mainly the safety of the surgery and safety of anesthesia. And that is when we take into consideration the other health problems the lady may have. Now, as we know, we all have our chronological age, which is our actual age. And we also have our biological age. So I've seen many 80-year-old ladies who walk in and probably even jump and hop into clinic who are very healthy. And there are some that are much younger, maybe in their 50s, but they are chronologically younger, but biologically older because there are more health problems. So that has to be taken into consideration as we personalize medicine for each patient, whether it is safe to proceed with surgery or not. Now, even if the lady is not fit for surgery, we should still undergo investigations because the majority of breast cancers, especially in the older ladies, tend to be estrogen receptor positive. So breast cancer, there are many subtypes. And for this group of women, even if they're not fit for surgery, they may be good candidates for hormone therapy, oral tablets that can help shrink or keep the tumor under control. And either this treatment or surgery can still help these ladies have a good quality of life for many years, prevent cancer growth. That means we prevent the tumors from growing bigger and forming ulcers and bleeds, or we prevent the spread. And that's still, so as long as the lady is still healthy and have many years to go, which we do have now because our women are living much longer, I think we shouldn't stop them from do not stop yourself from seeking medical treatment.
Right. Thank you, Yirong. I think that was very important. As you mentioned, our elderly patients, many of them are actually quite healthy and fit. And I think age itself is really not a factor to be considered independently. And we really need to take the entire patient profile into account in our treatment decisions. And sometimes that's just much easier and it's done together with the doctor as opposed to, patients making a conclusion just on the surface, from what they see.
Yeah, many ladies think they're very old, but actually they're still very healthy and fit.
Yeah, I agree. I have many patients, they have had to receive chemo after the age of 70, but even to the fact that I've not expected them to tolerate it so well, they actually do really well. And we keep wondering to ourselves, sometimes we underestimate how strong our patients are as well. Yeah. So, but it's good. I think it's thanks for sharing that with us. One of the things that we also were asked, maybe Lynette, you can take this question. Was, yes, we have imaging modalities to kind of help us pick up, breast cancer, but typically, it has to be a certain size. Now, increasingly, there's a lot of technology. Once again, we are going to technology about, liquid biopsies and tests like that, where they can detect cancer early. Is there a role for some of these new tests in the screening part of breast cancer, for example?
That's a very good question. So similar to what Yirong mentioned about thermal imaging, a lot of these tests are actually up and coming, very, very promising, very interesting, and we hope that one day blood-based tests will be available. But at the moment, a lot of our decision making is based on clinical trials where they have to test thousands of women and prove that it actually reduces the risk, it improves survival. So before we have that information, we can't quite commit to saying that this would be beneficial, but we certainly encourage anyone to participate in any clinical trials, including all these modalities. Probably the only blood-based test that is useful would probably be the genetic test to look for any inherited cancers that in which we can actually screen and prevent for. But otherwise, at the moment, it's akan datang,
Okay.
coming soon.
Coming soon. All right. So we had this question from one of our participants live today. Immunotherapy is one of the treatments. So this is a bit beyond, the topic of our current webinar, but maybe you could just give us a quick one-liner or two-liners about this. But immunotherapy has been used in the treatment of many different cancers, especially over the last 5 years or so, 5 to 10 years. Now, in breast cancer, do you see that, have you seen that the immunotherapy has come to the mainstream for many of the breast cancer patients that you treat? Yeah.
We hope so, but again, akan datang. Well, the problem is, okay, so immunotherapy works by basically boosting our immunity. So currently our bodies are unable to detect the cancer as being abnormal. So our immune system lives with the cancer and doesn't do anything to it. So we hope that immunotherapy is usually an infusion or an injection would then remove that cloak of disguise by the cancer cells, so our immune system can recognize the cancer cells as foreign and start to attack it. So instead of using chemotherapy or drugs to actually kill the cancer cells, we are harnessing our own immune system to kill those cancer cells. It has been very, very successful in a lot of other cancers like melanomas, lung cancers. Unfortunately, in breast cancer, it seems to be lagging behind. A lot of the clinical trials have not been very successful. However, there has been some early data on its benefit in a particular type of breast cancers called triple negative breast cancers. So it's very promising, and we are hoping that in the future, we will be able to find a space for immunotherapy in breast cancer treatment. But at the moment, its use is still quite limited, but there is a lot of promise. I hope that there will be more place for it in the future.
Definitely, yeah. And I think there are a lot of studies, at least, from what we are seeing on our clinical trials database of a lot of combination work that is happening, looking at immunotherapy plus other kind of treatment options. And hopefully there's a lot of growth in this space over the coming years as well.
Yep.
Thanks, Lynette. We've got actually 3 different questions that were centered around the same idea, which was second opinion. And even being asked live, and we got quite a few at registration as well. Now, I just wanted to get both your opinions, maybe just quickly. What is the role of a second opinion, at least in your practice, when you see patients coming to you? What kind of questions are they really coming to help address from a patient perspective? Maybe Lynette, you can start, and we can go to Yirong after that.
I guess if I were a patient, I would do my homework. So I'll first ensure that my doctor has the correct credentials, enough experience, and maybe speak to some of the patients of that particular doctor to ensure that they're happy with him. But I think it's the doctor-patient relationship that is more important. A lot of our treatment are based on guidelines, based on clinical trials and evidence that this proves that this is definitely effective, this is not effective, and we will usually follow those guidelines. So usually a doctor doesn't veer far off, but it's that relationship with the doctor that's probably a little bit more important. The doctor must be able to provide that support. So it's very easy. I can prescribe chemotherapy. Anyone can prescribe chemotherapy. Even a computer can prescribe chemotherapy, but is the doctor able to manage the side effects, manage the psychological overlay regarding all these treatments? So that is also important. So sometimes if a person is not too comfortable with a particular doctor, or you don't really have that trust, sometimes you may need a second opinion for that. But generally, if you have that confidence in your doctor, usually it wouldn't go far wrong.
All right. And what about you, Yirong?
Well, I agree with you, Lynette. So most of us, I mean, doctors, surgeons, oncologists, and radiologists all follow a set guidelines. So the opinion-wise, within at least our country, usually doesn't vary very much. But I always encourage my patients, if you have doubts or you have questions, I mean, it's your body. You're entitled to a second opinion, to listen to another doctor's opinion. And at the end of the day, it's all about the patient-doctor relationship. Is this doctor or the team that you're going to be treated by, are you comfortable to go this treatment of this journey together? Because treatment for cancer is just one stop. It's a journey that we walk together. Sometimes the second opinion comes in many forms. We get the patients who want another pathologist to read the biopsy specimen just to confirm that it is indeed cancer, or do the stains. Sometimes we get second opinions to look at the imaging, just to look through the mammogram and ultrasound again. And the other times we get a second opinion is the surgeon's opinion to the types of surgeries that we can perform. And also, of course, the oncologist, I suppose, the type of chemotherapy you do. So most of the time they're pretty much similar. And if you do need to get second opinion or third, do go ahead. But I hope that you at least get your treatment and don't run away from it. That's most important. And don't spend too much time shopping around. I know we shop for clothes or we shop for things. Cancer treatment shouldn't take too long. So as you seek your treatment, don't delay. At the end of the day, you do your homework, but don't delay the treatment. That's the most important thing.
Yeah. Yirong, I completely agree with you on that. And in fact, you know, as Oncoshot, as a service where we connect a lot of our patients with our community of oncologists, we get questions on, so should I go and see, you know, this particular oncologist for a second opinion, and what then after that? And I think most of the time, especially if you need a second opinion, once you're done speaking to, you know, the supporting oncologist, that should be more than enough for you to, you know, pursue your treatment plans. And it's very important that we don't delay our treatment in search for, you know, the supposed incremental change or difference that we can get by just going up to multiple doctors. And I think that's very important, you know, from the patient perspective to be understood as well. But certainly, second opinion has a role to play in giving that guidance and support and that confidence that you're on the right track. And once that's established, it really helps patients to move along in their treatment journey as well. And, you know, that's where we see this helping a lot of patients. Let me just address a question that was asked in the Q&A. I think it's a fairly common question that I've encountered in my practice as well. Elderly patient with who's menopausal, obviously. Now, and then they're being told that they have a hormone-positive cancer. Wow, this doesn't make sense. I'm already menopause. I should have low estrogen levels. Why am I getting a hormone-positive cancer? Open, this is for either of you if you want to take it.
Okay, so the female hormones, when you're young, they're produced by your ovaries, okay? And that's when you get your menstrual cycle every month, and it's all the estrogens that come in. Now, even when we menopause as women and our ovaries close shop and stop producing estrogens, we still have a few estrogens circulating in the body, and that is produced by this enzyme called aromatase, which is found mostly in the fats in your body and elsewhere. So even though we are, when you're postmenopausal, you still have estrogen levels in your body, but just a much lower level.
Yeah. All right. So, and that still drives, you know, the breast cancer. So I think that's an important concept that we need to have. It also importantly means that it's treatable, right? So we have agents that treat hormone-positive cancer, and you know, it's important that we seek treatment for them as well. Okay, let me just have a quick screen to see whether there's any other questions that we can address. Yeah, so there was a question about, you know, maybe Lynette, you could take this quickly about triple negative breast cancers. You know, what's really the difference between this group of cancers compared to, you know, for example, the hormone positive breast cancer? And for a patient example over here who's done fairly well at I think about the 4th or the 5th year after treatment, how does it look for them beyond that 5-year mark? And how would you perceive that for them?
Yep. So triple negative breast cancers are now understood to be more of a systemic disease. They tend to micrometastasize or spread to other parts of the body more quickly. They tend to be at a later stage of cancers. So usually the treatment is generally chemotherapy. Because the cells tend to grow faster, spread faster. However, the good thing about cancers that grow very quickly and spread very quickly is that they can be easily treated with chemotherapy and very, very sensitive to chemotherapy. So once all the treatment has been done, usually after many, many years, if there is no cancer recurrence, generally we would consider the cancer cured. So 4 to 5 years after the initial treatment, if all the complete cancer treatment has been completed, usually the chance of cancer recurrence is actually very, very low as compared to the other sorts of cancers, which are like estrogen receptor or hormone receptor positive cancers. Unfortunately, while they are more slow growing, there's always a risk of recurrence even 10 years or 15 years down the road. So there are just differences in behaviors, and therefore the treatment is also different.
Okay, right. Yeah, I think that was very helpful. So overall, as a summary, the profile of the behavior of the triple negative is actually quite different from the hormone positive ones. All the treatment options are limited. If they actually do quite well, they generally do well for a longer period of time as well. Yeah, sorry, you wanted to say something?
Yeah, one last thing. Triple negative breast cancers have been linked to a BRCA gene mutation as well. So that's the other thing. You need to consider whether you want to do a genetic testing to see whether there is a hereditary component, because if there is, then that risk needs to be addressed as well.
Thanks. Completely agree with you on that. Thank you. So I think we are probably at the end of our webinar. There have been a few questions that were asked, particularly in relation to side effects from treatment and minimization of side effects, as well as, for example, okay, there was actually another one on immunization. Maybe you can just end off by answering that one last question. Can I have my immunizations for regular viral infections while on maintenance HER2-directed therapy or hormone therapy? Lynette?
I think the aim of the immunization is to harness a lot of immunity or antibodies against that particular virus or the disease that we're trying to prevent. So usually if a person is on chemotherapy, the immune system is suppressed. Usually the immunity is not working so well, then the vaccination may not be effective. So generally we hope to immunize patients about 2 months before they start chemotherapy and about 6 months after they have completed chemotherapy. So that's about it. But if a person is only on, say, HER2-directed therapy, which is a targeted therapy, or on hormone therapy, these do not affect the immune system. So I don't think there's any issue having vaccinations done.
Okay, all right. So I think we are still getting quite a bit of questions, but a lot of these questions are also, what happens after I receive my treatment? How do I manage some side effects from treatment? And I think the great news from all of this is that, we are hoping to conduct quite a few webinars over the coming weeks to address different kind of issues that patients may face in their entire cancer treatment journey. So maybe what we'll probably want to do is on our end, at Oncoshot's end, we'll try to collate all of these questions that have not been answered and try to incorporate them in our subsequent sessions where we'll be looking at addressing, what happens on treatment, during treatment, what happens after treatment, and how can you take care of yourself. And maybe we can have a bigger opportunity or a better opportunity to take more time to go through that as well. But with this, I'd like to come to an end with for the webinar. I want to say a big thank you to the 3 of you for participating in this webinar. I think it was a great learning experience for a lot of our participants as well. And I enjoyed moderating the session with the 3 of you. As always, even despite the fact that I'm also managing cancer patients, it's just nice and good to kind of learn about these things with your own perspectives thrown into that as well. So that was really nice. So thank you, everyone. With this, I'd like to say have a great weekend and look forward to the Breast Cancer Awareness Month. Please make sure that you go out there, learn more during this coming month, and share this information with your families and friends so that every one of us is informed about how to manage and take care of ourselves from preventing breast cancer. Thank you.
Thank you.
Thank you.
Bye.
Bye.
Bye.